So I'd like to take just a few minutes now to explain to you the development of the pediatric versions of AirQ. I'm an adult anesthesiologist, so I didn't really have an appreciation of the differences that and the problems that the pediatric anesthesiologists have with supraglottic laryngeal airway devices. Now, most of the other companies out there simply just took their adult sizes and sized them down for infants, and I think that's the main reason why sometimes that these airways, at least the laryngeal mask airway devices, don't work so well in infants. So I decided to take my time in the development of the infant airways. So I traveled around and I spoke with a bunch of pediatric specialists in multiple institutions so that I could get a feel for the differences and the needs, special needs for the pediatric anesthesiologists. And I did this, and working in collaboration with several of these doctors, I come up with a different design for the two small infant airways, and I'd like to share what I found. So this is the size 1.5 pediatric AirQ. And I think the biggest thing that I realized was, after a discussion with multiple people, was that there was significant difference in the anatomy of the airway device for small infants below 2 years old and what we see for adults. And I think the differences are important, and that they translate into a necessary shape difference in the pediatric airways. So what we did was, and this is the size 1.5 pediatric airway, and I think I'll show you the difference. One of the things, the first thing I did was make the curve of the tube a little tighter. Because of the high occiput of the infants, the babies tend to lay supine on tables in a relatively flexed position. So I think it was important that we increase the curve there. The other thing I did was I changed the shape of the mask. And I think if I show you the difference between, this is the size 2, which is a more adult-shaped device, and this is the size 1.5, I'll show you the difference in the shape of the mask. The adult shape size is more of a elongated taper, because as infants become older, the airway starts to stretch out, and it changes from a very short, wide airway with a very anterior larynx to an elongated shape in the adult. So what I did was I made the infant cuff shorter, wider, and flatter. So that, in the combination of the slightly higher bend in the tube, allows the AirQ to fit the space better for infants, and I think it's because of that this airway sits in really anatomically correct, and it increases the stability of the airway once it's placed within the infant. Functionally, the infant airways are very similar to the adult airways. You can use these as standard airway devices every day, or you can use them as intubation conduits to intubate infants. I think what sets apart AirQ with the other masked airways and as an intubation conduit is that it was built to do this. So you can use standard endotracheal tubes, and you can also use cuffed endotracheal tubes through the infant airways and remove the airway device without sacrificing the cuff. So let me show you how it works. To use the AirQ infant as an intubation conduit, it's important that you remove the, as an adult, it's important that you remove the connector from the end of the tube. Now this will shorten the barrel and allow you give you more room to put the endotracheal tubes in. Now you can use standard cuffed endotracheal tubes, so this is the size 1.5. This size we use somewhere between 7 kilos and 17 kilos, and this is a standard 4.0 endotracheal tube. So this would be a tube that I would probably use through this size of device. The first thing you do, just like an adult, is you want to make sure that all the air is out of the cuff of the endotracheal tube. You want to lubricate the end of the endotracheal tube by putting some lubrication on here. Now, as the AirQ is in the infant, you just put the endotracheal tube and run it back and forth and lubricate all the way through and through. Many people then just place the endotracheal tube in a partially inserted position and then run a flexible bronchoscope through the endotracheal tube into the trachea. Some physicians would rather load the endotracheal tube onto the flexible bronchoscope first, run the bronchoscope down into the trachea, and then simply advance the endotracheal tube in the trachea. I think both work equally well. Once we have the infant intubated, I think it becomes important then to remove the AirQ. And we use a similar sort of device, the AirQ removal stylet, that's specifically built for infant airways. Now this is a size 00. Now, the only difference is it's a slightly different way to use the removal stylet in infants than adults, and let me show you how that works. As an adult, you want to remove the connector of the endotracheal tube. that instead of putting the removal stylet in and twisting it in, I simply just push it in until it engages the endotracheal tube. Now, because the pilot balloon is so large compared to the opening and the lumen of the airway device itself, it makes it difficult for the pilot balloon to pass through and through while the stylet is in place. So instead of allowing the stylet to pass through completely the air cube, what I'm going to do is I'm going to start removing the air cube until the pilot balloon is just about ready to enter. I'm going to reach down and stabilize the endotracheal tube at the mouth. And you can get a helper to help you, and often it helps to have another set of hands. At that point, you simply remove the stylet from the proximal end of the device, pull it through and through, and then pull the device through out and remove it. Replace the connector on the endotracheal tube, adjust the depth, and reinflate the airway device. So it's actually the same maneuver as the adults. It's just instead of letting the stylet go through and through the device with the endotracheal tube, just before the pilot balloon enters the lumen of the air cue device, pull the stylet out the proximal end, and then pull everything out over the endotracheal tube and remove the air cue. So in conclusion, I think the infant air cues are really novel new devices. Their specific shapes designed for infant anatomy not only makes the insertion quite easy, it makes the airways stable once they're placed, and because of their design, it makes the use of standard cuffed endotracheal tubes possible with the infant patients. I think this combination allows AirCube, I believe, to be a very effective ventilatory tool and a very important rescue airway device in the infant population. So the insertion of the infant air cue is actually quite easy. While there are lots of different ways to do it, and some can be more successful than others, I think the easiest for me is this. Simply extend the infant's head, lift the tongue. Some people use a tongue depressor, some people just reach in and hold the jaw forward. Place the air cue in your hands with your finger on the cap and support the tube with the rest of your fingers. Place the air cue in on a forward angle if possible. Wiggle it a little bit and push with your index finger to slide the air cue into place. It's really quite easy. So it's more of a rotational feel than it is a push. So let me again show you again. Lift the tongue, place it forward, rotate it in, and that's all you need to do. Now, inflation of the baby air cue is very similar to the adult. I use the red tag on, so I leave the red tag on to open the valve. I take the red tag off once it's in, and if I think it's necessary, I put just a little bit of air. Typically for the size 1, it's less than a cc. So it's very easy to put the air cue in. It's very stable once it's in there, and just put little bits of air, and I think you won't have any problem whatsoever.